Suspect over there, so as you look gave the chief of plates of swelling over the left knee joint since birth and pain over the left knee since 8 years. Asked he had a history of.
Okay, what is your proper diagnosis when there is a painless swelling around the knee joint? Any explanations? Any idea? Have you seen any case of any painless swelling around the knee joint near posting? You're about to go to your examinations. Have you heard anything like osteochondroma, exostosis? Have you seen any case of that? Yes or no? You are understanding? Yes or no? So this is a case of osteochondroma of left knee. So which is the common site where you will get osteochondroma? At least you have read osteochondroma. If not, you have seen a case. Osteochondroma is a benign tumor. Okay, it will be usually seen around the knee joint. Okay, and in your findings, it will be covered with a hyaline cartilage. It will always go away from the joint space. All right. It may be penetrated or sessile. Which are the most common ones where you get a sessile osteochondroma, and which are the common sites where you get a penetrated osteochondroma? Because those things I can ask anyone, I can point and ask someone. Any idea? Okay, mostly the sessile osteochondroma will be seen around the flat foot side, humerus or upper lip, humerus or the scapula, and the penetrated will be mostly seen around tibia, femur. All right. So how will you make a diagnosis? As I have always told in my classes, any case in a medicine profession will have etiology. What are the causes? Any age group specific for this? How will you make a diagnosis? And how will you confirm a diagnosis? And how will you treat? This being a benign tumor or any tumor for that reason, it will say which is the common site from which it originates. It will be a epiphyseal tumor or metaphyseal tumor or diaphyseal tumor. Alright, this is a it will be a epiphyseal outgrowth. Alright, osteochondroma away from the joint line. So how will you make a diagnosis of it? X-ray will show a penetrated lesion on the outgrowth from the joint. MRI will show a hyaline cartilage. For this, the treatment will be excision biopsy of the skin. Alright. Is it mandatory to remove all the exostosis? Only when the thing becomes symptomatic, when it compresses from now, or when it complains of extreme pain, you will have to go for removal. And ideally, removal should be done after the bone fuses. That will be better. Otherwise, recurrence will be common. Alright. The other sort of features of osteochondroma can be single or it can be multiple. When there is multiple exostosis, it will be mostly associated with some syndromes. Alright, Mollier syndromes or some other syndromes will be associated. Alright, these are the basic things that you need to know about an osteochondroma. Most of the time it will be, as I told you, it will be asymptomatic. When it can become symptomatic. Any common condition where it can become symptomatic. When the patient has a fall and any fracture of the peduncle occurs, it may become painful and it may require immediate removal. Alright.
The case yara totu parala. Ama. See. Yeah. Ndama beringu. Sapara kalli. See, this is a case typically having a complication of exostosis, multiple exostosis. You have a simple exostosis case. Simple exostosis na solitary or multiple. as very nallave ellame sollitaru, but the point is number one, it starts, our patient notices the growth, not at birth. He cannot be noticing his growth on birth. He cannot be. So what will be happening is they'll be noticing the growth when they are in their adolescence or prepubescence. That's where the growth spurt happens. When the growth spurt happens, the cartilage grows faster. That's why we gain weight in a prepubertal spurt region, where the age is around 10 to 13 years, and girls will be having somewhat earlier spurt. Okay, so during that phase, the swelling will manifest because the cartilage will be growing in an extraordinary fast fashion, and there is an eccentricity in this. There won't be a central exostosis, which may be very rare. There is always an eccentricity. And that eccentricity will be moving away from the growth because the person has outgrown his original tumor, original swelling. The growth was there. But since he has grown, since the limb has become longer, the swelling will be moving away from the joint, as if it is moving away from the joint. Because the swelling has happened earlier, the person has grown, and the swelling's position relative to the growth plate is very, very different upon the ages. That's why apparently it will be seen as if it is going away from the growth plate. Okay, nothing away from the growth plate, sir, normally the growth plate. So the swelling is noticed during the growth spurt or the prepubertal region, and it continues to grow till the growth stops. So the patient can present at any time, any age. Depending upon the age, we have to decide. If it is a very younger individual, no treatment is necessary unless otherwise it is having a complication. And as I told you, silent features are, it is growing around the fast growing regions of the body. Which are the fast growing regions of the body? In the upper and lower limb. In the lower limb, it is around the knee joint. In the upper limb, it is around the shoulder joint. So more frequently we encounter exostosis, or more frequently we notice exostosis in these two areas, because the growth phase is maximum on these areas. The limb lengthening happens maximum on these areas. That's why we have more swelling around these joints. It can happen in any place. I have dissected a case of exostosis on a callus that we have presented. So it can happen at any point. Okay. So it's an abnormal growth plate phenomena, and it is noticed first in the growth spurt or the prepubertal phase, and it will continue to grow as the patient grows. And because the growth is continuous, the swelling appears as if it is growing away from the physeal plate. It's just an apparent change because of the age, number one. Number two, the complications are, we call certain diseases called the multiple physeal plate deformities. There are SEDs, there are many deformities, we abbreviate as SED and MPDs. Multiple epiphyseal dysplasias and spinal epiphyseal dysplasias. These are the conditions that involve multiple physeal plates. He is one amongst the conditions. He is having multiple swelling around the knee joints, and it involves multiple places of both upper limbs and lower limbs. And because of that, he is having a deformity. This growth deformity has happened because of the persistent physeal growth that is obstructing the intrasacral space. Patient is unable to do his supination and pronation. கையை எப்படி வச்சிருக்கீங்க, உடம்பு எப்படி வச்சிருக்கீங்க, கையை எப்படி திருப்பி, கை மடக்கு, இப்ப கீழே திருப்புங்க. He cannot cross the mid pro. கையை மேல திருப்பு, மேல திருப்பு, மேல திருப்பு, திருப்பி கீழே திருப்புங்க. He cannot go beyond mid pro. That means his intrasacral space is compromised. He is having a growth deformity that is manifesting with the deformity of the forearm. That means one bone is pressing over the other bone because of the abnormal presence of the swelling as it grows, deforming the entire forearm. And there may be involvement of, as you palpate, you can see multiple swellings in his forearm also, as well as around his knee joint. These are the swellings which are bony hard in consistency. You can pinch the skin. Whenever a swelling is present, you have to ascertain the plane of the swelling. The plane of the swelling starts from the skin. If you are able to pinch the skin, I am able to pinch the skin. That means it is not adherent with the swelling. Both skin and subcutaneous area are free. If we pinch, subcut also comes along. The only area is QD orange. It is a lymphatic change that we see it as a you typically see the QD orange phenomena, and that's where the presentation is different. Beyond that, if the skin is pinchable, that means up to subcutaneous it's free. Okay, and then there's not much of angular called madak layer. Okay, madak so this is more of a subcutaneous bone. We cannot make much. But if it is under the muscle, what will happen? If the swelling happens below the muscle, this is arising from the bone. That means it is typically below the muscle, isn't it? What will happen? The size of the swelling will be apparently getting smaller if we put the muscle to contraction. The muscle is taut. If the swelling is adherent to the muscle, what will happen? If it is superficial to the muscle, it will be pushed up. It will be more visible or prominent. If it is under the muscle, it will be less prominent. If it is in between, there will be loss of movement in the plane of the movement. If the muscle is firm, the swelling is attached to the muscle, you cannot move it in one plane. Which plane? Yes. Only the perpendicular direction movement we will be having along the two plane directions. Okay. Here, this is a subcutaneous plane. The swelling is free and it is going up to the level of the bone once you palpate. You can continuously palpate the other bone and continuously palpate the parent bone as you go down. Okay. It is arising from the bone. This is a typical. What is the sessile and the peduncle? There is a gap in between the swelling and the original parent bone, which is linked by a small twig or a branch. We call it as a peduncle or a branched swelling. If it is a sessile ones, that means a small bump is happening, just like a dome it is there. Okay, so this patient is having multiple exhaustosis, and this exhaustosis can become a problem because it is a restricting and deforming roots. This is one of the complications. Other complication, as I saw told, because of pathological fracture, the stalk can be fractured. Okay, a bursa can happen because of the pressure effect over the particular swelling. It can compress the neighboring bone, as in this case. It can compress the neurovascular structure, producing a pressure effects. Okay, so a bursa can be present superficially, beyond which it can produce a facial disturbance affecting the entire anatomy of the limb, and it can press upon the structures that is nearby, which may be another bone or the neurovascular structure, or it can fracture upon itself, or it can become a tumor on a rare occasion. Tumorous condition of osteochondroma is very rare, it's less than 1%. Even it will be very rare because all the osteochondromas are not existing. Many cases are just not being recorded. So very rare presentation will be there. What type of tumor it will become? The pathology is with the cartilage only. Growth cartilage only is the pathology. That means it is the yes, that's the only problem. The chondroma. Yes, that's the only probability that can happen. Okay, so this is a person with a swelling that is bony heart, that is near the growth plate, and it has grown along with the patient for a certain time, and it has stopped beyond that. Number 5 is it is multiple in location for this particular case, and there are changes because of the pressure effects. There's a more complication. Until date, he has not presented any complication pertaining to tumorous malformation. That means malignant malformations. Malignant malformation is possible in these cases where the swelling is inaccessible. He is also having a swelling in his scapula. If you palpate carefully, you can also have a swelling in the flat bones. That is having a probability of getting into malignant transformation. And if the cartilage in the scap is very thick, you are having a probability of malignant transformation. All this being covered, you can see the case and then discuss.
அவர் கையை மட்டும் பால்பேட் பண்ணுங்க.